Thank you very much, Chair and colleagues and friends. Good morning. My name is Harry Wang. I am currently working at the Chinese University of Hong Kong. So my topic is to talk about the use of PCAT in China and Hong Kong. So similar to other regions around the world, the PCAT instrument is also very popular in China and Hong Kong. And in Hong Kong, we have a PCAT research group led by Professor Samuel Wong. And the members include myself, Professor Martin Wong, Professor Xiaoling Wei, Professor Sean Griffiths, and also Dr. Donald Lee from the Bohemia Foundation Research Center, and also mainland collaborator, Professor Jiaqi Wang, working at Guangzhou Medical University. So this is the primary care assessment tool, which has been developed by the Johns Hopkins Primary Care Policy Center in the United States, and it's a patient self-report instrument measuring patient experiences rather than the satisfaction towards the healthcare services they received. And it's measured the extent and quality of these services. And the PCAT skills has 9 skills representing 5 primary care domains, including first contact, continuity, coordination, comprehensiveness, and also community-centeredness. And this is a widely used instrument around the world and also in China and Hong Kong. And I did a very simple search on the PubMed on February the 28th this year, and to find out how many publications are there so far with regard to the use of PCAT in both mainland China and also Hong Kong. So I found 6 results from this search platform. So here are a list of the articles which you might want to look at the full text of these articles for your easy references. So to start, first of all, we might think about why do we want to assess the primary care in China and Hong Kong, and why is it so important for us to measure it. And recently, our colleagues at the Chinese University of Hong Kong has published a book called Routledge Handbook of Global Public Health in Asia. And in this book, me and another colleague in mainland China has written a chapter on developing primary care in China. So if you are interested in this book and this book chapter, you can feel free to search it on the internet, which you will find more information about primary care in China. And China is a very large country with the world's largest population around the world. And the health system covers 1/5 of the people in the world. In 2009, there's a comprehensive healthcare reform in China consisting of 4 key pillars, including health financing, care delivery, drug supply, and hospital reforms. And strengthening primary care services are being put at the top priority under the care delivery pillar. So in terms of the structure of the healthcare system, there's primary care versus secondary and tertiary care in China, and the outpatient services are available in most healthcare facilities. And unlike the United Kingdom, there's no gatekeeper system in China. And also the services are not free of charge, so which means patients need to pay for their services. There's a national social medical insurance, but the insurance system just offers very limited benefits package. So most of the healthcare remains on a fee-for-service basis and private out-of-pocket payment. So in recent years, there's a rising numbers of the community health centers being established in urban areas as the major primary care providers. And they provide a 6-in-1 comprehensive care package, including prevention, health protection, treatment, rehabilitation, health education, and also family planning. So which we call the 6-in-1 comprehensive care package as the primary care services in mainland. And compared to the secondary hospitals and tertiary hospitals, the primary care facilities, which we call community health centers, is small in scale, but is designed to provide major preventive and curative services for the vast majority of the population. So under the recent healthcare reform, the community health centers are considered as major primary care provider in urban areas. It provides both Western and traditional Chinese medicine services. And of course, it's not free at the point of access, so patients need to pay. In terms of the professionals, most healthcare staff have similar working hours at the CHCs, and the healthcare staff working at these primary care facilities are paid a fixed salary plus a floating salary, which is largely determined by the total income of the CHC. And pre-registration at these CHCs are not necessary, and patients need to pay for the fees including examinations, treatment, and drug expenditure. So this article might be the first article published using the PCAT in China. And this article evaluated the PCAT instruments with regards to data quality and measurement properties by Yang Hui using a population in Hunan province. So this is a cross-sectional survey. It aims to translate and adapt a 63-item version of the PCAT instrument, and it did the validity and reliability analysis using standard psychometric techniques. And it recruited the patients from the outpatient departments of hospitals of all levels and community health centers in a province in south-central China. And it interviewed over 2,000 patients who were 18 years or older visiting the primary care providers on the date of the interview. And on average, the version they used lasted for 30 minutes. And the authors did the forward and backward translation and also Delphi procedure, followed by pilot testing. So in terms of the content validity, the percentage of the response category, not sure or don't remember, ranged widely from 0.8 to 35.3%. And the authors assigned a median value of 2.5 to those answers that are not sure or don't remember. And they used the principal component analysis to yield 9-component solution with most of the items factor loadings being significant. And in terms of the internal consistency, they evaluated the item convergent and item discriminative validity, and they found that all item scale correlations exceeded 0.5, with the majority achieving a correlation of at least 0.6, which demonstrated that the instrument was quite good and was useful and appropriate for assessing the core attributes of primary care. And the versions they developed achieved a relatively good validity and reliability. So this was the maybe the first articles using the PCAT in China published on the International Journal of Quality in Healthcare. And later, there's another research group in Fuzhou province in eastern China using the PCAT instrument to evaluate the primary healthcare service in the Fuzhou city in the context of health sector reform using a mixed method study. And they used a PCAT version consisting of 36 items to evaluate the primary care services based on clients' experiences. And the study site was in Fuzhou City, the capital city of Fujian province on the southeast coast of China, which is one of the wealthier provinces in China. And they purposely selected the study sites for convenience. And they also interviewed all adult patients 18 years and above, and to compare the quality of services provided by hospitals and also community health centers. And they used a similar analytical methods compared to previous studies to calculate the PCAT scores. And they found that patients attending community health centers are more likely to report better experiences with primary care attributes than those who are attending hospital outpatient departments. However, they found that for the community orientation, family-centeredness, and coordination skills, all types of healthcare facilities had relatively lower scores. And later, another research group used the PCAT Chinese version in the Tibet provinces, and recently published in Biomed Research International. The study site was in Tibet Autonomous Region in western China, in that region, most residents are minorities and they could not speak Mandarin Chinese, so there's a need for them to develop a Tibet version of the PCAT. And in that version, they had 28 items. And the authors did a principal component analysis to measure the construct validity and also some other reliability analysis. And they found that compared with the prefectural hospital and county hospital outpatient department, the township health center achieved highest primary care quality scores. So from this map, we could see that there are several research groups across China using the PCAT. So we had one in Western China, had two in Eastern China, and other two in Southern China. And in Hong Kong, in Hong Kong and Pearl River Delta, we also had a research group. And the Pearl River Delta is a network of 6 cities, which is the most densely urbanized region in China. And we think this is a very good place to investigate the whole picture of China's primary care development, because we think it's a snapshot and trendsetter of the healthcare policies. So this is an article published by me and Professor Samuel Wong, the principal investigator of the research group, in an international journal of medicine. We evaluated the attributes of primary care in community health centers in southern China, and to see whether having a medical insurance would make a difference to the services received by those patients. And we used a 33-item version of the PCAT adult short edition. We did a forward and backward translation process, and we found that the Chinese PCAT version has good language comparability and also interpretability similarity compared to the original version. And we also assessed the psychometric properties of this version. So our results found that most patients reported a moderate to strong affiliation with the community health center as their primary care provider. However, only 1/3 of these patients reported having a regular doctor at the CHC. And also treatment of acute conditions was the most frequent, followed by diagnosis and follow-up of chronic conditions. So the community health centers are being used widely for treating acute conditions rather than chronic conditions. And we found that 1/3 of the subjects had an optimal score, which is defined as having higher than the 3rd quantile of the score range. And in the community orientation scale, we found that most of the respondents reported a lower PCAT scores. And also we found that there are differences in the PCAT scores between insured and uninsured subjects. So we draw a predicted probability chart showing the PCAT scores between patients with medical insurance and those with not. And we found that patients with social medical insurance had higher odds of having greater experiences in most of the primary care attributes, and they report better primary care experiences. And this effect remained the same after we adjust for other confounding variables. And later, we also did a study to compare the different models of primary care in China to see which model provides the best care and to see whether the differences in the models is related to the overall PCAT scores. So overall, there are 3 different types of community health centers in China. The one is government-owned CHC, and the other is hospital-owned CHC and the privately owned CHC. They had similar characteristics in terms of the staff structure and services provided, and also the industry supervision. But they had differences in terms of the ownership and management, and also the financial support from the government. So for the government-owned CHCs, they received most funding, or entire funding from the government. And for privately owned CHCs, most of them need to invest the facilities by themselves. And also they had different mechanisms in terms of the revenues and expenditures. So for government-owned CHCs, they return all the revenues to the government, and they got all the fees from the government. So there's a separation between revenue and expenditures. However, for hospital-owned CHCs and privately owned CHCs, they are to some extent quite self-independent financially. And so this article was published on the Annals of Family Medicine, which is the #1 journal in the primary health care. And we found that respondents gave the government-owned and managed CHCs the highest overall PCAT scores as a result of better first contact utilization and coordination of care in terms of service coordination and information system. And also we found that from the regression analysis that the hospital-owned and privately owned CHCs tended to be associated with lower PCAT scores compared to those owned by the government. And the conclusion was that the organizational model of these CHCs is associated with differences in primary care quality as measured by the PCAT. So for the government-owned community health centers, they had better performance in first contact utilization domain, as that we found service users are more willing to utilize these facilities as their first contact care. And also in this type of CHCs, they had better performance in service coordination and information system domain, which we think might be because of the central planning and multi-sectoral collaborations by the government. And this would achieve better control of services, would achieve better control of resources. And also the government might have higher public accountability for providing good healthcare services. And in terms of the privately owned CHCs, they had lowest overall PCAT scores, especially for those chronically ill patients. And also they had poor performance in the coordination domain, which may partly because of their lacking of incentives and policy support to coordinate these medical services. So these are the literatures from China. And here we're going to talk about the PCAT studies in Hong Kong. And as we know, Hong Kong has an entirely different system compared to China. So in Hong Kong, we have a separation between public and private sector. So for outpatient clinics, part, more than 70% of services are provided in the private sector, and 30% of services are provided in the public sector. So in the public sector, we have general outpatient clinics and and in private sector, we had those private general practitioners or private clinics. And similar to China, in Hong Kong, there has also been a comprehensive healthcare reform, which aims to enhance primary care. And developing primary care conceptual models and clinical protocols are also being put as one of the priorities to develop a feasible service model to deliver enhanced primary care services. And this is a typical example of the healthcare situation in Hong Kong every month. So for every 1,000 people, slightly more than 1/3 would use primary care for Western allopathic medicine. So in Hong Kong, the earliest studies on PCAT was conducted by Professor Samuel Wong, the PI of the research group. And they compared the primary care experiences between the public sector and also the private sector. And they did a telephone survey among 5,000 general populations. And they found that 20% of them reported using the general outpatient clinics in the public sector, and also nearly 80% of them reported using a private GP as their primary care. So they found that patients receiving care from private GPs reported better primary care experiences than those using the services in the public sector, so which is totally different from the results in mainland, where the private CHCs had lower scores, and in Hong Kong, the private GPs had higher scores, so which may due to the differences in the healthcare system. And later, the research group did a repeated study again, and to confirm the study results of the previous study, and they found that the patient's socioeconomic status were associated with the quality of primary care they received. And they found that the quality of primary care experienced in Hong Kong tended to be higher for those who had higher income, and for these groups of population, they also tend to use private GPs. So the results were quite consistent. And most recently, the research group also did a comparative study between the primary care services between Hong Kong and Shanghai using the PCAT instrument, and the results are going to be published in PLOS ONE later. And they found that the quality of public primary care tended to be more equitable in Shanghai compared to in Hong Kong, which may also be due to the differences in the healthcare system itself. So here are a summary of the comments from these previous researchers. And so first of all, the higher rate of favorable responses and the sizable rate of not sure or don't remember may be particularly common among Asian populations. And also the researchers commented that the patients reported quality assessments may not be able to capture every aspect of care because patients themselves had limited technical knowledge. And also the predictive validity of the PCAT to link scores with the achievement of favorable outcomes may be one of the future directions to work with. And another researcher reported that there are limitations with regard to patient selection in most of the studies, and also the study results might be influenced by the geographic accessibility, because some patients generally do not have choices but to attend the site that is the closest in distance to their place of residence, so this might be limitations. And for our research group, our comments would be that the patient's experiences might be easily influenced by the severity of the health conditions, and we were not able to quantify these health conditions using the current PCAT instrument. And also there are many unmeasured and confounders potentially existed between different ownerships and management of the community health centers and PCAT scores. And we were not able to use the symptoms or disease-specific outcomes, and therefore, the PCAT instrument that we're using is more related to the process rather than the outcome of the care. And also, the study did not evaluate whether the primary care services were cost-effective and evidence-based too, and this might also be another area to develop in the future. And also, most studies in China and Hong Kong were cross-sectional, so it does not allow for demonstration of the causality. And as we know, the healthcare system worldwide being developed and have many challenges. And in China and Hong Kong, we also have many challenges in terms of the practice itself and also the health system. So in mainland China, under the healthcare reform, the payment methods may profoundly alter the practice behavior. So the current performance indicators in China tend to overemphasize the income and service volume in the community health centers, and these indicators are less concerned with quality and health outcome of the whole and entire population. And also there's a shortage of well-trained general practitioners, particularly in mainland China. And there are many reasons for this, and one of the reasons might be that there is limited acceptance and trust of having a gatekeeper for healthcare. And also there's a widespread attitude that the generalists are less competent and professional compared to the specialists. And also the GPs working in the primary care sector may have heavy workload or poor working environment, so they have less promising care opportunities in the primary care setting. So these are challenges from the practice perspective. And also we have challenges from the rising chronic diseases. So in a recent study published in BMC Medicine, we found that more than 1 in 10 of the total population in mainland China had 2 or more chronic conditions from a selection of 40 morbidities. So there's also a rising challenge from the chronic disease, which may bring about a heavy burden into the healthcare system and particularly the primary care sector. We know that there are differences between the health systems across the world, and there are also some similarities in the healthcare systems around the world and in the regions. And in the most recent study published on the Annals of Family Medicine, we used the relationships of multimorbidity and income as an indicator to demonstrate the differences and similarities across the 3 healthcare systems consisting the UK, mainland China, and Hong Kong. So we found that in Hong Kong, the public healthcare sector is very much similar to the UK's NHS system, and the private sector in Hong Kong is very much similar to the mainland China's healthcare system. So we have similarities and differences in the health system. We have challenges from the chronic disease. We have challenges from the practice. And there are so many challenges that we need to conquer and to address. So based on the Donald Bedien's framework of structure, process, and outcome, the current use of PCAT are heavily focused on the process aspect. So in the future, we might need to consider how it could reflect how the primary care sectors are working towards addressing the challenges from chronic disease, the shortage of GPs, and also the system characteristics. And we may need to look at how the primary care are being developed and improved with regard to healthcare coverage, fee-for-service payments, and also out-of-pocket payments. So we might need to find the ways to link the PCAT with the ultimate outcome of the entire population to make the use of PCAT more reasonable and more informative, so that we can have more first-hand evidence, so that we could further develop and strengthen our primary care system. So that's the end of my presentation, and thank you.
Thank you.